Good morning, or good afternoon, depending on when you are in the world. My name is Andrey Levitskiy, and together with my colleague Joanna Nayler, we're going to present the work we have done earlier this year at Pamela Steele Associates, exploring common best practices in human resources across health supply chain organizations in Africa. Pamela Steele Associates is a management consultancy which specializes in supply chain transformation for the public health and humanitarian sectors through consultancy, research and training. We have offices in Africa, England. Currently, we're leading a supply chain transformation program in Ethiopia, supporting the Ethiopian Pharmaceutical Supplies Agency, or APSA, to improve its organizational performance, build organizational resilience, and achieve sustainability of their supply chain. One of our work streams is focused on supporting the human resources transformation within the agency. We conducted this study to help our experts and consultants in the field, as well as senior leadership at APSA, to get a clear understanding of current human resource practices and trends in similar supply chain organizations on the continent. The importance of human resource management as a pathway to organizational resilience has been widely discussed in the literature. The transformation of human resources has been closely linked to business critical issues and how organizations can effectively address disruption and mitigate risk. Over the past decade, the scholarly focus on human resource management has expanded to include supply chain organizations, given that major donor and advocacy organizations began targeting workforce development and HR transformation. USAID, UNICEF, and People That Deliver initiatives, to name but a few, address the issues of professional development of health workers, linking academic degrees to the pressing demands of the health sector and the critical shortage of health professionals in Africa. They also focused on promoting specialization and certification in supply chain and fostering the professionalization of the supply chain community in a bid to create a clear pathway for continuous professional development in this field. People That Deliver, in particular, developed approaches towards the optimization of workforce performance through the theory of change. They have mapped out pathways that connect interventions and investment in human resources to health supply chain performance and suggested how it could be improved. People That Deliver proposed 4 pathways of change. First, creating an adequate pool of workers to fill crucial supply chain positions, then concentrating on developing and improving their competence through professional training, learning and experience, improving working conditions, including organizational work culture, to support the supply chain performance, and finally increasing motivation through performance appraisals, awards, and various incentives. So we took this approach as the foundation of our academic investigation into HR transformation and approached supply chain organizations in Africa to find what steps they have taken to strengthen their supply chain. We began with a thematic analysis of human resource management practices by going through peer-reviewed publications, strategy and policy papers, program reports, etc., to paint a big picture. Then we conducted an online survey among supply chain professionals in Africa to collect qualitative and quantitative data on human resource management development and practices. Finally, we approached senior HR specialists in 6 parastatal health supply chain organizations for in-depth interviews, going through every transformation pathway to capture practices, achievements, and challenges faced by each organization. Here you can see the map of supply chain organizations that we have studied. These include the Ethiopian Pharmaceutical Supply Agency, APSA, the Kenya Medical Supplies Agency, KEMSA, the Central Medical Stores Trust, CMST of Malawi, the National Medical Supplies Fund, NMSF of Sudan, the Medical Stores Department, MSD of Tanzania, and the National Medical Stores, NMS of Uganda. The first point of our academic inquiry was to look through the recruitment process in supply chain organizations. An important starting point for a supply chain organization is to draft a list of crucial supply chain positions and identify staffing requirements for these roles. Most of the survey respondents highlighted that the job descriptions developed by their organizations included such key elements as clearly defined and detailed job objectives, essential professional qualifications, a range of decision-making responsibilities, and clear reporting relationships. An essential feature of recruitment is a competency-based focus, meaning that the selection process identifies candidates with valuable knowledge, skills, training, and experience that underpin their successful performance in supply chain roles. A competency framework sets out and defines competency areas that serve as key performance indicators for employees in their roles and levels of performance. The survey demonstrated that competency frameworks are now widely used components of human resource management for supply chain. 75% of respondents indicated that their organizations follow a competency framework in the process of developing or updating job descriptions. We found that the recruitment process within supply chain organizations in focus was carefully planned and guided by a special human resource manual, for example in CAMSA or MSD, or terms and conditions of service in CMST. These documents mapped out the steps, responsibilities, and protective measures to ensure a smooth recruitment process. HR departments most often identify hiring need by collecting job requisition forms from departments. These requests were checked against the budget and staffing requirements for each division before initiating the recruitment process. Organizations such as CAMSA and national medical stores first attempt to fill the vacant positions internally. Advertising is conducted via corporate email, newsletters, and the HR department then reviews the qualifications of internal applicants. For example, in CAMSA, the HR department assembles a panel for a suitability test, looking specifically into qualifications and skills, as well as the length of work experience in the organization, past performance, and disciplinary records. For certain positions, CAMSA organizes external recruitment. They're also encouraging internal candidates to apply. Similarly, in the national medical stores, if the HR department is unable to establish qualifying internal candidates for vacancies, it begins external job advertising, publishing in social media, on the organizational website, and the national print media. The application process is conducted both online and by post. Ad hoc interview panels and recruitment committees are assembled to conduct interviews with shortlisted candidates. In some organizations, the recruitment and interviewing for top management position is outsourced to professional services companies. For example, CAMSA outsources to Deloitte, or governmental organizations. In case of MNSF, it's the National Civil Service Commission, and in case of MSD, it's Public Service Recruitment Secretariat. Before the interview, candidates often sit special assessment tests to establish their competence level and essential technical skills for the job. Such tests are conducted at MSD, NMS, and APSA. Other organizations such as CMST and CAMSA incorporate technical questions into the job interviews with shortlisted candidates, alongside traditional HR questions and behavioral assessment. When asked what were the decisive factors in selecting certain candidates for the role, our respondents highlighted that the primary focus was on relevant professional experience and qualifications. Fitness for work is equally important. A key informant for the National Medical Stores of Uganda emphasized that the behavioral assessment of candidates and their ability to fit well within the rest of the team was among the decisive factors for recruitment. All supply chain organizations in focus invested significant effort in capacity building activities. CAMSA, APSA, CMST organized coaching, mentoring, and on-the-job training. The organizations specifically encouraged self-study activities, membership in professional associations, and obtaining professional qualifications and higher degrees. Most of the studied organizations outsource their training activities and try to carefully manage often limited training budgets. NMSF relies on the facilities of its Abdelhamid Ibrahim Training Center, opened in 2017, and APSA at the moment is planning to create a similar training and resource center. Now I'm going to hand over to Joanna, who's going to take you over through various aspects of organizational culture and performance management.
Thank you, Andrey, for the introduction and for outlining the first few areas of best practices. I will now take us through the next few areas before concluding. Our study also examined areas relating to working conditions, particularly focusing on organisational culture and the policies that enable this, and policies and practices that promote women or members of minority groups. Organisational culture is an important component of creating a supportive work environment, providing a way for employees to voice their views and develop connections and purpose. The study identified several key policy areas to support organisational culture, and having an overarching code of conduct or ethics in place was the most common policy intervention listed by survey respondents. 63% said they had one in place, and these were also found to be in place at all of the 6 case study organisations. Other common policies mentioned to promote organisational culture included anti-corruption or anti-fraud policies, anti-sexual harassment or anti-discrimination policies, HIV or chronic disease policies, and health and safety policies and procedures. Within the area of health and safety, which is an important part of creating a good overall work environment and encompasses psychosocial threats and gender-based violence as well as physical harm, respondents also listed processes such as carrying out tests, for example, lighting conditions and air quality tests, providing medical cover and free health checks, and providing protective equipment to staff. Now, policies alone are not sufficient to improve working conditions. Policies should be regularly reviewed and steps taken to ensure implementation. The respondents mentioned how their organisations sensitise employees on and disseminate their policies by means of consultation, regular reviews, printing out hard copies, and uploading soft copies to the intranet. NMS in Uganda is also in the process of designing online modules covering its policies. In the area of supporting women and members of minority groups, respondents commonly emphasise the importance of non-discrimination in terms of recruitment and employment. Some of the 6 case study organisations also had specific groups or departments focusing on this, for example, the Gender Mainstreaming Committee and the Disability Mainstreaming Committee at KEMSA, and the Gender and Youth Directorate at EPSA. Other procedures mentioned by respondents included using affirmative action in either recruitment or promotion, having a clear policy on attracting and maintaining an equal workforce, and examining disaggregated data on the gender split at different levels. We will now focus on practices used in African health supply chain organisations to increase and ensure motivation. Key ways to enhance motivation identified by the study include performance management processes, for example, through the use of appraisals, promotions and incentives, and employee engagement and retention processes. This section will look at these themes, showing how each case study organisation identified has its own unique combination of intrinsic and extrinsic motivators. So beginning with performance management, 73% of the survey respondents confirmed the presence of performance management systems at their organisation. Further, performance appraisals were central to motivation across all of the 6 case study organisations. These were conducted annually or biannually, using either the balanced scorecard tool or 90-degree or 180-degree appraisal methods. MSD in Tanzania also uses its own internal appraisal system known as Drive. Promotions are also an effective tool to identify, develop and manage work performance. The study identified a range of promotion systems, including a career progression plan at KEMSA, the condition of service handbook at CMST, and a competence-based promotion system in MSD. Financial and non-financial incentives can improve supply chain practices through improved staff motivation and enhanced collaboration. A range of performance incentives and work benefits to enhance the motivation of staff were identified by the study. This included financial incentives, such as hardship and transport allowances, for example at MSD, and non-financial incentives, such as rewarding employee performance with a recognition letter and a dinner with the CEO at KEMSA. The study identified a variety of tools that are used to improve employee engagement and staff retention, an important motivator to improve work efficiency and job satisfaction. A few of the 6 case study organisations have developed structured retention schemes and policies, such as KEMSA's Talent Management Manual, while others resort to various monetary and non-monetary incentives, as previously mentioned, work benefits and organisational changes. Employee engagement and retention approaches mentioned included supporting professional development, such as offering study leave or covering fee costs, improving internal communications, and fostering a sense of company loyalty. Providing supervisory support was another key factor mentioned, with different approaches taken. For example, KEMSA encourages systematic supervision, whilst NMS aims to boost interdepartmental coaching and mentoring, especially for junior staff. This concludes our presentation, which has explored human resource transformation for building a resilient supply chain, exploring common best practices in African health supply chain organisations. We have looked at a range of areas, including recruitment, staff capacity building, organisational culture, performance management, and employee engagement and retention. We'd like to thank the respondents who generously gave their time to enrich the study, the Global Health Supply Chain Summit and its sponsors, and everyone listening. My colleague, Dr. Lakshmy Subramanian, will now be available to answer any questions. Thank you.
To start off, I'm happy to start with a question. Lakshmy, what is one of the most surprising aspects of this research, in your opinion?
Thank you, Emily, and good afternoon, good morning, and good evening to everyone. I think the most surprising element for our team to be doing this research was usually it is considered that most of these parastatal agencies that we spoke to do not actually have a system in place as far as human resources are concerned. It can be a bit ad hoc, etc. But when we actually spoke to most of the key informant from these parastatal agencies, it was we were glad to realize that they do realize the importance of human resource transformation for robust health supply chains. And I think the COVID situation reiterated the importance of human resources all the more. And most of the time it's because of some budgetary constraint or lack of resources that they are not being able to implement most of the interventions that are also recommended to them. So I think the learning experience for us was like most of these agencies are aware of where the lacunae is. They are getting, I would say, I won't say adequate, but to start off with enough support to say where they need to go. And I think with that, and it doesn't take place in a day, it's like a change that has to happen with people, so that takes time and that takes a lot of motivation as well. So I think that has been a surprising and learning experience for us overall as a team.
Great, thank you. And it looks like we have a question from Bruce. Do you think that appraisal systems, promotions, or incentives are the most influential in performance management?
Thank you, Ruth. I think when we spoke to each of the parastatal agencies, motivation is very relative, and we saw that each organization did not have one specific tool that targeted. So ultimately, it came down to having employees who are committed to what they are doing and having a sense of ownership, and that can be very difficult to achieve in health supply chains. So that's where depending on the context in which a parastatal agency is and the challenges that they are facing, each organization had some kind of incentives, and we found that in most cases non-financial incentives went a long place in retaining people than financial incentives. And in order to motivate them, medical insurance played a very key role. They also, and we had very good examples from Sudan, especially in NMSF, where there was a complete change in the ambience. There was an introduction of cafeteria. There were some mobile credits that were given to employees. So so when the organization understood what the employees actually needed, so I would say it was a combination of incentives, and also promotions are very relative because might be certain organizations don't have promotions. For example, like they have a 4-year contract, like for NMS doesn't have any promotion concept. Every employee gets a 4-year contract, and again, it's renewed after 4 years depending on the opportunities that are available. So I think it's a combination of everything together that works for the parastatal agency, basically.
Great, thank you so much. I think we have time for about one more question before we go to the second panel. It looks like we have another chat submission from Stephen. Where do employees leaving the central medical store find other employment? I'm interested in the positive aspects of this with skills gained while working at a central medical store and where else they could be applied, as well as the competitive aspects. Are there challenges for central medical stores to retain strong talent given other employment alternatives?
Okay, thank you, Stephen. I think one thing that we did realize is most of the capacity building procedure, capacity building workshops or professionalization efforts have failed to create an enabling environment for these individuals who come for these courses. So especially when we are trying to work with EPSA, or when we try to work with EPSA, we see, yes, there is a gap in the markets, especially in health supply chain, where people are not happy with what they are doing in central medical stores, and even the private sector is not strong enough to absorb them into the market. So that's a challenge that we too identified, and might be we can have platforms, or we could have collaborations where we do need strong support from the international community to think about it. And also most of the countries, I feel, do not have, it can be a case where most of the pharmacists are entering health supply chain. So there can be a gap in terms of the skill set. So we need to identify exactly where do we have these employees leaving the central medical stores fit the entire health supply chain. So it could be either the donor community or the private sector. But unfortunately, these are not very strong in most of these countries that we did the survey and we spoke to. So that is a lacunae we to identify through our survey.
Thank you so much for your time, Lakshmi, and your team as well for the presentation. We really appreciate it. And now we are going to move into the second session of this conversation. So I'm going to turn it over to our second group.
Thank you very much, Emily. I appreciate that. And thank you for the presentation that was just done. It was very interesting. So good morning, afternoon, and evening, everyone. Thank you all for joining us today. My name is Maeve Magner, and I'm delighted to be moderating the panel on innovating for malaria supply chain resilience in a time of crisis, especially as it's bringing a country perspective. As we all know, information is important in supply chain decision making, and even more critical when we're looking at times of crisis. But for information, we need data. And it isn't just about the data, but it's how we use that data. And that's going to be the focus of our conversation today. Just to let you know, we won't have any PowerPoints. It will be all discussion. We would encourage you to use the chat box to add your questions or comments while we're doing the discussion, and we can consider those as we're going along. But we will have some time at the end for questions and answers. I will ask the panelists now if they can put their videos on. We were having technical difficulties, so hopefully everybody is on. But what I would like to do now is to introduce our three panelists. I will ask each of them to briefly introduce themselves, and then we'll move to the discussion. So let me go first to Rwanda, and we're going to talk to the Director of Monitoring and Evaluation at the Rwanda Biomedical Center. So Donasio, if you can please go ahead and do a brief introduction. You're on mute, Donasio, so you may need to come off mute.
Hello.
There you go, we can hear you.
Thank you very much, Maeve. Thank you very much, participants. My name is Donatien Tagarangabo. Donatien is a French name. I'm basically French speaker. English is my third language. I'm directing RBC. I'm heading the unit called Monitoring and Evaluation. I'm now 7 years working in RBC. Basically, my professional, my work is to track performance of health indicator across all program of RBC. And I'm also in charge of doing data quality assessment in health facility. We have around 500, more than 500 health center and around 43 district hospitals. So I'm in charge of data quality and supportive supervision across all these health facilities. As my background, I have a master's in global health delivery, obtained here in Rwanda and the University of Global Health Equity. But also I have a master's in project planning and management. So briefly, this is what I do like profession.
Alessia, thank you very much. I'm very impressed that you get to do all of that and still get all your education at the same time. You're a busy man. Thank you.
Thank you.
Next, I'm going to go to Zambia, and I'm not sure if Japet is yet on the line. Do we know if he is there? Let me go to Kaluba first. So I'm going to introduce you to the Genesis Zambia country manager, Kaluba. So if you don't mind, can you go ahead and do a quick introduction?
Thanks, Maeve. And good afternoon, good morning, and good evening, everyone. As Maeve had introduced me, I'm Kalua Mataka, working with Genesis here in Zambia. What we do is we work in terms of supporting the Ministry of Health as well as the National Malaria Elimination Center with systems integration, data triangulation, and bringing their siloed systems together there's a platform that we've built called the Zambia Health Analytics Platform, where we're looking at data from the various systems collected at the Ministry of Health, particularly around supply chain, in order to support their data analytics and decision-making processes. I've been working with the ministry for close to about 13 years now with various projects and different organizations, with a particular emphasis on systems implementations and building systems just to assist the ministry in terms of data management and data analytics. So that's just a brief introduction about myself.
That's awesome, Kaluba. Thank you very much. We have a third panelist, the principal biostatistician from the Zambia National Malaria Elimination Center, JEPET. But unfortunately, I think he's having some problems in dialing in. So once he is coming on, we will come back to get him to introduce himself. In the meantime, what I'd like to do is just set a little bit of context for the discussion that we're going to have today. As we all know, and as we have been discussing over the past 2 days, this pandemic has had a significant impact on supply chain. I think the upside is everybody now knows what supply chain is and why it's so important. However, the downside is that it has had massive impacts on transportation disruptions, which has limited the movement of goods and increased the cost of supplies. We've seen unprecedented demand for COVID products, which has actually created a bit of a Wild West market, and speculative buying with those for deep pockets. And unfortunately, that has created a challenge for many of the low and middle income countries. However, this has also driven a stronger collaboration among the global health partners and governments to ensure supply of COVID medical equipment, diagnostics, medicines, and are now working on the availability of vaccines, the supply of these products for low and middle income countries. However, the pandemic has had additional adverse effects on disease programs such as malaria. With these interruptions and supply challenges happening at the same time that the rainy season is coming in and the incidences of malaria are rapidly increasing. We've also seen disruptions in the supply of anti-malarials as people have been buying them up to use for COVID. We've seen impact on the disruption. We have seen disruptions on the supply of malaria RDTs as the raw materials for the RDTs have been shifted across to COVID, as has the manufacturing capacity. So all of this creates additional burdens for these programs. So what we want to talk about today is how the malaria programs in Rwanda and Zambia are responding to these challenges and the role that data plays in all of that. So with that, I'm going to go to the first question, and I'm going to ask Donacio, if you can talk to us a little bit about the impact of COVID in Rwanda and specifically in your work in the malaria program. You're on mute, Donacio.
Sorry. As such, there was not really big impact in terms of delivery of products, but what you know is that during lockdown, we had to be proactive on distributing malaria commodities. So what we have been doing was just to collect data from the SysCom. SysCom is one of the platforms that we collect data on potential stockouts or actual stockouts, which is reported from community health workers to health facility or health center level. So from that platform, we collect data. We identified some places or some villages. Village is in the organization structure of local administration. Village is the lower level where community health workers do perform and provide service to the community. So we did a kind of analysis of data, and we find areas or communities where there is potential stockouts of drugs. Then what we did, it was just to do a kind of active distribution to allow that we can have sufficient drugs and commodity like RDT in the community. Basically, that is what we did as the way to address or to take advantage on issues that related to stock out. But also what we did, it was a kind of redesign the way of doing supply chain. Normally, LL9s is provided from their facility so that people can come to their facility to take LL9s. But what we did was to be just proactive, to take LL9 from health center and to use community health workers to do active distribution for women who came who want LL9 for ANC services or those who came for vaccination. Basically, this is what we did around malaria data, malaria issue. We did also some advanced or proactive action toward analysis of data and taking action for other services like HIV, like cancer service. So if really you are also interested on what we did, we can just give also what you did in terms of overcoming issue of stock out or any issue around supply chain. For example, in HIV, you know, we have what is called DSDMI, which is under differential service delivery for currently people on RET. You know that some people are unstable or clients are unstable, others are stable. Those stable do take drugs for 3 months, but those unstable, they take drugs just for 1 month. So what we did was just to redesign the way of giving drugs so that those who are unstable could take drugs for 2 months, And what this was done just doing analysis in electronic ELMIs, which is electronical, logistical, medical information systems, where we could populate data and to increase the maximum of stock supply, so that at a facility level or at district pharmacy level, they cannot have a stock out. So we increase the maximum level so that we can supply for 2 months for those who were unstable. So regarding also for cancer, we have 2 treatment center of cancer. So what we could do, it was just there were some strategies that were taken during COVID, because people could not move from the place to treatment centers or cancer treatment centers. So what we did was just to agree with the Zipline, which has the drone delivery system. So Zipline could go and deliver drugs to very remote areas so that patients can have drugs, cancer drugs, at the very nearest place where they are located. So I think this could not be done without really the using of existing platform. And regarding with data, I think RHAP, which is a Rwanda analytic platform, which was developed by Genesis, really allowed us to have a full picture of all programs' performance. As an example, we could do combination of supply chain data from one instance called ELMIS, another instance called HMIS, and another instance called Syscom, which is for the community. And we could do really triangulation of data in order to identify gaps in resource utilization and distribution. So having a kind of platform like RHAP had helped us really much to get broad picture of how we stand in terms of data. So having really good data helped us to take prompt action. Thank you.
Thank you, Donasia. I wanted to just build on that for a minute, if you don't mind. So when you talk about the different systems and being able to bring that data together and triangulating it, in our discussions, yesterday, and that you talked about the value, the advantage that you have, because you can now try and triangulate the data and analyze the data better. Can you talk a little bit about that?
So, basically, people take data from one instance, they extract them in Excel, they do data cleaning. After that, they produce graphs, which takes sometimes longer, whereas people need very quick data with the good outputs like tables and graphs, so that to take prompt decision. So with RHAP, which helped us is we have different instances. We could populate easily data from the community. Data from when I say data from community, it's because we have what is called malaria home-based care, where people are treated at a community level, and those data are reported in Syscom. We have also data in HMIS, where data came from health center and district hospitals. So in normal condition, you have to extract data from those 2 instances. But with RHAP, what you can do is just it populates all data from different instances, like I'd say HMIS, Syscom, but also in ELMIS. And from that, just with a few click and point and doing some basic operational mathematical operations, we can have a global picture of how we have discrepancies, or we have gaps in terms of maybe drugs that have been consumed in both health center and community, versus cases that were treated or are diagnosed at health facility and community, and also the related positive test for both two parts. So with RHAP, it could really help us to get, I would say, at one point and click and have really the broad picture. RHAP also is helping us to identify outliers in reported data. Outliers are not necessarily false or false data. It can be a kind of situation that helps you to say, okay, there might be something in specific health facility or community where there is an increase of cases. And with RHAP, we can just drill down and until you go to the facility that are responsible for that big data. And from that one, we can call directly a facility and tell them why of this extreme outlier. It may be issue of data quality, but also it may be an issue of maybe increase of cases. So basically that is what RHAP has helped us. And also identifying missing values or empty data. This is also very, very important. That allows us to know that there is not only completeness, but also if there is completeness, but completeness may be also have some pitfall inside, which are really blank data that are reported. So it's the mix of all this stuff that helped us really to do quick analysis and have a good product or good output of data for us to take quick decisions.
Excellent. So, I mean, basically, it's not just about having the data, but it's also the timely access to the insights that you can get by bringing all these different data sets together and allowing you to be very focused and really understand the underlying issues, but being able to respond as needed as well. I believe Japet is on. So Japet, if you don't mind, I would like to have you do a brief introduction. You are on mute, so you'll probably need to come off mute. Can you hear us, Japet? Perfect. Yes. Would you mind going ahead and doing a quick introduction?
Okay. Let's remove the volume for me. Please remove the volume for me. To the TV. Music.
Sorry, bear with us for a moment if you don't mind.
Hello?
There you go. Can you hear us
Hello?
now?
Hi. Yeah,
Hi.
this is me.
Welcome, welcome. Thank you. Sorry you had
Sorry,
some...
I had food poisoning last evening.
Oh, we're sorry to hear that. Thank you so much
Yeah.
for the time to join us. We appreciate it.
Oh, thank you. And I'm out of town right now.
Okay.
So it's about a quick introduction.
Please, thank
of
you.
myself. Yeah. So I'm Jafet Chiwawala. I'm a principal biostatistician working with the National Malaria Elimination Center under Ministry of Health. Yeah, so my background basically is economics and demography from Zambia. Then I did my MA in Massachusetts in the USA. So that's briefly about me. Thank you.
Thank you, Jabet. While we have you, can you also talk to us a little bit about the impact that COVID-19 has been in Zambia and how that has impacted your work?
Okay. In terms of COVID, this is a global pandemic, and it has impacted, I mean, all nations, great and small nations. But in terms of Zambia, what it has really impacted us on is mostly on in terms of supply chain management. So it has impacted basically in 4 areas. It has reduced access to commodities and also malaria interventions. It has also led to delay in delivery of key malaria same interventions, commodities, then also delay in delivery of key interventions. Also, there's been a global shortage in terms of malaria commodities, RDTs and malarials. And then the fourth one, it has led to increase the programmatic costs because this is something we didn't anticipate. So you need to factor in all these costs that are coming in because of COVID. So basically, that's what this pandemic has led us into. Thank you.
Thank you very much, Jepet. We appreciate that. Kaluba, I'd like now to go to you and your role as an implementing partner. Can you talk a little bit about how you and your organization have supported the governments in Rwanda and Zambia during this crisis?
Sorry, would you repeat that one?
Jepet, this is for Kaluba.
Yeah.
I will come back to you in just a minute.
Oh, okay. Thank you.
Thank
you. Thanks for that question, Maeve. So what our role has been, I think has greatly been in terms of giving access to officers within government and within these program areas who previously never had access to this system. So, for example, you have your GHSCS-2020 operating at the national level, and program staff, even within the central level, did not necessarily have direct access to these systems. And so what we have been able to do as an organization is firstly, integrate all of these systems, your ELMIS data. In Zambia, we have the Malaria Rapid Reporting System, which is a separate GHIS2 instance from the one that the ministry uses for malaria reporting at facility and community level.
Sorry, Kaluba, the connection is not very good.
System which operates at
Kaluba,
the national, provincial, and district level, which is another separate. Hello?
Yeah, Kaluba, sorry, we missed some of that.
Can you hear me?
Yeah, there was some disruption.
Can you hear me now?
Yes, we can.
Can you hear me? Hello?
Yes, Kaluba, we can hear you.
Can you hear me?
Yes.
Hello?
I think maybe she's having some technical problems.
Okay, can you hear me now?
Yes, Kaluba, we can hear you. Go ahead, Kaluba. Okay, sounds like Zambia is having connection problems today. Kaluba, are you still there? It looks like she may have dropped off. So I'm going to come back to Kaluba when she comes back on, but I'd like to go back to Dinasio and Japet, and I actually want to talk a little bit about how you have leveraged supply and disease burden data and innovative, scalable technologies to inform the intervention. So basically, how are you using the data and these new technologies to inform actual interventions for malaria and other diseases in your country? So Japet, can I ask you first?
Thank you very much. Lily, in terms of the COVID, this is something that we didn't anticipate. This is something that is an uncertainty. So in terms of leveraging our supply chain and in terms of data and everything else, we've really depended on the programmatic data, as Kalua was mentioning, the GHSCS-2020, which is in more than almost 3,000 health facilities across the country, which is a monthly reporting system. We also leveraged on the Malaria Rapid Reporting System, which is a weekly reporting system, a malaria instant that we've developed to enable the country as we forge ahead this malaria elimination. So that's about 34% of health facilities, at least now in the, we can say they are reporting less than 200 cases per 1,000 population in terms of instance. So literally we've worked together with Genesis to make sure that what we are seeing right now, in future, we can really try to avoid, sort of, because hello?
Yes, Japet, we can hear you.
Okay, yeah, because from third quarter last year up to fourth quarter, because as you may be aware, I don't know if you are not, but we are earmarked for a malaria elimination in the country by next year. And by third quarter, fourth quarter last year, we started seeing trends of increase in malaria cases. Cases have increased, like even compared to last year, first quarter last year, January to March, and first quarter this year, we've increased cases by more than 40%. Malaria deaths have increased by more than 50%. So, which is not very good for the country, and a country that has impact on malaria elimination. So we are saying with Genesis, we need something like an early warning system. We spoke with Kalova and the team that we need an early warning system that will allow us to enable detect something unusual in terms of our data, because we are working hand in hand right now with them, and we are trying to inbuild something in the system that can allow us to detect something unusual in the data that will inform the program, say, no, this ABC, there's something unusual, so that as a program we can act. So we've really been caught unaware by this coronavirus that we can't deny, but we need something that can really help us to detect and also respond. So we've engaged Genesis to help us to see the mechanism that they can put in the system so that we are able to detect the uncertainties and the unusual behaviors in our data system. But the data we have, we report through the routine system, monthly, as well as we've got a weekly system that we are trying to expand as a country. Thank you.
Thank you very much. That's very, very good. I appreciate that. So what I want to do now is I want to go back to Danasia, and I want to talk a little bit about data quality, because again, you know, we're seeing the importance of the data. We're looking at how we can aggregate it and use it, but obviously the quality of the data is going to be very important. So Danasio, can you talk to us a little bit about data quality?
Thank you, Mavi. Data quality first starts with building the culture of quality of culture of data from peoples. What we do is we do many things, but the most important thing is that periodically we do what is called the data quality assessment, where we select key indicator at central level, and those key indicators are assessed in the decentralized level on all the district hospitals and referral hospitals, but with some selected health centers. So what we do is to go to the fields and health facilities to check data that has been reported at central level, and we compare them with the actual data that are in primary sources like registers, file patient. From that, we draw the discrepancy, and right after the field visit at health facility, we provide a recommendation, actionable recommendation with exact timeline so that we can see if there is a change. For district hospitals with the discrepancy above a threshold which is accepted by SOP, what we do, we tell them to correct the data, but the correction of data is done under a respectful or respected procedures, which mean that health facility, the right to central level, an electronic message, email, requesting them to correct the data, but also to provide the reason of why there is those discrepancies. From that now, we have people or staff dedicated to that who open the system and allow them to do data correction of data. This is one part of what we do, like data quality. But another part is we upgraded SOPs, and we stressed on the validation of health facility data. The validation is done by all staff involved of data at health facility level, but also the validation is backed by the management of the health facility. So before they report data at central level, that has to be validated. To be validated means that the health manager accept that for this and this and this and this particular data, I agree that they are of good quality before reporting it. And we have been seeing very decrease of data quality issues on that. What also we do is to develop what is called a Metadata Dictionary that explains health facility data manager on the definition of each and every indicator and the definition of each and every data element, so that they can know that this data element has this particular definition, and where is the place of, or the source document where we can go and collect those data. Also, we with RHAP, you know that it has developed a data quality tool that's from where we can check the completeness and timeliness of reported data, but also it's helped us, I said it above, it's helped us to identify missing values and some outliers from national level to the very last entity, reporting entity. So also, we set at district hospital level what we call coordination meeting, where we discuss issue around data and where we take actions for change. Action are not necessarily punishment. Action are such as to give induction to new data manager, to organize e-learning sessions for refresher training, but to some extent also where it's really needed, action may be the effect on performance-based funds, which is one way of cutting the fund for someone who misbehaved in terms of poor quality data. We also initiate a lot of instructions around data quality. The instructions are issued from the Ministry of Health to all health facilities in terms of providing staff in charge of data from going outside of their facility for any kind of training or mentorship, but they have to be kept in the facility in a specific period, which we called a reporting period. It takes around 2 weeks, and from that specific period, all people in charge of data have to be in health facility for data collection, for validation meeting, for reporting, and for other quality check. So these are issues around how we try to address data quality. But there are many. We can't talk them in these few minutes we have. Thank you.
Thank you very much, Donacio. I really like your approach, in terms of really looking at the root cause, trying to address, the reason why the data may not be correct, and whether that's training or whether that's motivation. I also like what you're saying about having dedicated people for the data. I think that that's important, and I really like this idea of the data people at the health facilities having this period of time to where they have to be at the health facilities, and really locking that into the reporting period. Sounds really really good and very progressive. I want to go back to Kaluba. Are you there, Kaluba? Can you hear us?
Yes, can you hear me?
We can hear you. So yeah, if you wouldn't mind just going back and talking a little bit about the role that you and your organization have in terms of supporting both Rwanda and Zambia.
Yes, thank you. So as both Donatella and Japheth have indicated, what we really try to do is to bring these previously siloed systems under one platform, to enable program officers and decision makers to have quick and easy access to all of their data sources and their data points, so that they can be able to triangulate all the data from the different systems. For example, your malaria case data from HMIS to your malaria commodity data coming in from ELMIS, to even your community data coming in from systems such as the malaria rapid reporting system here in Zambia, and be able to see is there what story is the data telling us in terms of, we're seeing an increase in patients. Are we seeing a similar thing happening with commodities? If we're testing more, do facilities have commodities, or are they stocking out of commodities? So that then decision makers can be able to make decisions right there and then, because now they have access to this data as it is coming in, and they can be able to make quick and efficient decisions. And where they're seeing that there are stockouts in facilities, can they reallocate stock from other centers to facilities where they're, for example, seeing a lot more malaria cases? What we're also doing, as Japheth had mentioned, is, for example, here in Zambia, we worked with the Malaria Center to really look at the trends of increase in malaria cases, starting from third quarter last year right through to this year, to try and see where are we seeing the increases. Is it countrywide? Is it specific regions? And what interventions can the center come up with, because we've been seeing these increases. So for us, it's really about giving access to program officers and decision makers data that they can use for decision making. As was previously mentioned, in the past, you'd have somebody going into GHIS2, pulling out a report, having to work in it in Excel, then going into another system, pulling out a report and trying to make sense out of the data, which sometimes would even take even more than a month to just summarize a report. And so what we do is sit with the users, identify their data sources, bring all of these systems together, and then work with them in terms of analysis, in terms of data triangulations, and also building models to help them even forecast where they're going to see increases and build out trends within their data to just help them better manage their programs and using their data.
That's great, Kaluba. Thank you so much. We are coming to time, and I don't actually see any questions. If there is anybody out there that have questions, if you want to post them on the chat or raise your hand. But in the meantime, I'm going to go back to each of the panelists and just ask to close out, to give some last thoughts to share with your colleagues in other countries as they're dealing with their challenges. So can I first go to Japet? Can you share any last thoughts with your colleagues here? Can you hear us, Japet?
Sorry, technology. Yeah, I can. Are you able to get me?
Yes, we can hear you now.
Okay. No, so my last thought, I think I'm coming from different backgrounds. I think we've shared this with Kalova. I've worked in the Ministry of Agriculture, and there the early warning system has been paramount in terms of giving the government insight. Now the season will be when the rains are starting, when the distribution of the seed is supposed to be of fertilizer. So I think even in the midst of health, as we also asked Genesis to help us with the early warning system, I spoke to Kalova and Aaron in terms of what we really need as a program right now. In terms of the rainfall data, it's very important for malaria programming. So I chatted with her. No, we need malaria data in the Genesis platform. It will really help, big deal for the program, because right now she's part of the National Malaria Elimination Program right now, because she's dealing with malaria, and even Genesis is dealing with malaria. So if malaria data, rainfall data would come in the platform, that would be a big deal, because we know that malaria is affected by 3 things: the vector, which is the mosquito, the environment, as well as the host, which is the person carrying the parasite. So if rainfall data would come in our platform, I think that would be a very big deal. And also just to emphasize of building an early warning system in the platform, to saying where are we seeing epidemics. So literally we need to have an epidemic blue book as a program in order to ascertain that this is an epidemic or this is not. Thank you. I submit.